I'm Mostafa Nawar, Professor of Cardiology, Alexandria University Hospital, and Head of Electrophysiology and Pacemaker Lab in Alexandria University Hospital. My lecture today will be in the form of a case study with a clinical presentation and the management all through according to the guidelines. Our patient is a female, 67 years old, who presented with chronic heart failure, long-standing atrial fibrillation, left bundle branch block, arterial hypertension, and type 2 diabetes. Her medical history began in March 18, where she presented for the first time to hospital with acute heart failure. The echo showed dilated cardiomyopathy, and coronary angio was done, which showed normal coronary arteries, and the guideline medical treatment for atrial fibrillation and heart failure. Her second admission was in July for worsening of her heart failure symptoms. In November, she presented with refractory heart failure symptoms, and she was referred for consultation. When first seen, she was dyspneic at rest on minimal exertion with severe fatigue. She showed tachypnea at rest, no obvious signs of congestion, blood pressure 130/70, and heart rate atrial fibrillation 77 beats per minute. She was in NIHA class 3. The ECG showed atrial fibrillation, as you've already seen on the slide. Atrial fibrillation with a left bundle branch block pattern. The QRS duration was 152 milliseconds, and the rate was 77 beats per minute. The end diastolic dimension was 62 millimeters. The end systolic dimension was 51, ejection fraction of 30%, mitral regurg moderate to severe, functional mitral regurg, as I've already seen in the echo. It showed also a left atrial size of 61 millimeters, left atrial volume index 58 milliliter per meter square, and the chest X-ray showed an enlarged cardiac silhouette without radiographic signs of pleural effusion. Hence, the diagnosis of congestive heart failure was done, and the patient was managed accordingly. Her lab showed hemoglobin of 14 grams per liter, blood glucose 6.9 millimole, hemoglobin A1C 8.8, serum urea 7.1 millimole, creat 101 micromole per liter, creatinine clearance 64 milliliter per minute, sodium within the normal range, as well as the potassium. N-terminal proBNP 701, and high sensitivity troponin was negative. The medical treatment that she received in November 2018 was in the form of bisoprolol, enalapril 20 milligrams BID, spironolactone 50 milligrams, torsemide 5 milligram once daily, apixaban for atrial fibrillation, and metformin 500 milligrams per deciliter, 500 milligrams twice a day. Question 1. What action could be done to optimize patient's management? Could we increase the diuretic dose? Consider DC cardioversion for atrial fibrillation. Consider catheter ablation of atrial fibrillation. Replace ACE inhibitor with sacubitril valsartan, or consider both sacubitril valsartan and CRT. First, concerning the diuretic dose, it's important to mention here that she showed no congestion, but almost the heart failure or the forward failure more than backward failure. Little congestion although she was in dyspnea class 3, and NIHA class was too low, atrial fibrillation diminishing further the cardiac output, and cardioversion. Concerning cardioversion, it was a chronic persistent atrial fibrillation, and the left atrial size was above 6 centimeters. That's why we didn't consider cardioversion for such a patient. Atrial fibrillation ablation may be an option in such patients, and have already the history have shown several papers, especially from Hasager lab, showing that the atrial fibrillation ablation may show some regression of heart failure symptoms in these patients and improvement, although the left atrial size may be an obstacle for such a patient. She was on enalapril for heart failure on the maximum tolerated dose, and by that time sacubitril valsartan became an option for management of patients with heart failure, and considering replacement of the well-tolerated ACE inhibitor with such a new combination became an option. And as long as the patient has left bundle branch block with such a very wide QRS complex exceeding 150 milliseconds, CRT may be considered. Cardioversion, if unstable, may be of value. Anticoagulation, according to stroke risk prevention, should be valid. Normalized fluid balance with diuretics to improve symptoms, although she wasn't congested. Control rate, the initial rate target for less than 110 beat per minute. If persistent heart failure or atrial fibrillation symptoms, inhibit the renin-angiotensin aldosterone system, early consideration of rhythm control, advanced heart failure therapies, including devices and treatment of other cardiovascular diseases, especially ischemia and hypertension. As long as our patient is a non-ischemic patient with a rate control 77 beats per minute, and she was already on diuretics and RAS blockers, but she didn't yet receive any form of the advanced therapies by that time, which is sacubitril valsartan therapy. The management DC cardioversion or atrial fibrillation ablation wasn't possible. Adjustment of medical therapy, bisoprolol, enalapril, torsemide, spironolactone, apixaban, metformin, and dapagliflozin. And the clinical dilemma, whether to use sacubitril valsartan or expose the patient for CRT therapy. Whether to begin with any of them is not wrong, because the patient had left bundle branch block, permanent atrial fibrillation, which is long-standing, and the management should include both. Angiotensin sacubitril valsartan is recommended as a replacement for an ACE to further reduce the risk of heart failure, hospitalization, and death in ambulatory patients with heart failure and ejection fraction who, with the reduced ejection fraction, who remain symptomatic despite optimal treatment with an ACE or beta blocker and on mineralocorticoid antagonist. The current status, NIHA functional class 3, left ventricular ejection fraction 30% or less, and terminal pro-BNP 701, and more than 4 weeks on stable optimal medical treatment, including bisoprolol, enalapril, and diuretics. Sacubitril valsartan 50 milligrams BID instead of enalapril was initiated in November 2018. But still, we have the evidence of the paradigm heart failure in patients with atrial fibrillation included in such a study around 37%, and they have shown already improvement in such patients in spite of the presence of the atrial fibrillation. Clinical presentation, why not CRT? CRT in patients with permanent atrial fibrillation results from the resynchronization therapy for ambulatory heart failure trial, the RAFT trial, CRT versus ICD. It showed the CRT improvement in the hazard ratio concerning heart failure, hospitalization and death, and also improvement in cardiovascular death and hospitalization rate, and improvement in the quality of life. And the study, the RAFT trial, have concluded that patients with permanent atrial fibrillation who are otherwise CRT candidates appear to gain minimal benefit from CRT ICD compared with a standard ICD. Yet the problem in these patients is that the rate is too high, and we have some options to manage these patients, either use of AV blocking agents in very high dose to minimize the ventricular response of the atrial fibrillation, or we may expose the patient for other maneuvers, which we'll mention later on. And 3 months later, in January 2019, the patient status was as follows. She's still in class 3 heart failure, ejection fraction 30 to 35, and terminal pro-BNP 662, and on optimal medical therapy and sacubitril valsartan increased to 100 dose. Could we add CRT on top of such a treatment? The patient was listed for CRT management. So the patient went from March 2018 to January 2019 through 3 hospital admissions, the first in July, the second in November, and the third in January, where the optimization of medical treatment was carried out, and she was considered a candidate for CRT therapy because she's still complaining of refractory heart failure in spite of the optimal medical treatment she's receiving daily. So it should be considered in patients with ejection fraction less than 35%, and NIHA class 3 or 4, optimal medical treatment in order to improve symptoms and reduce morbidity and mortality. If they are in atrial fibrillation, has or a QRS of more than 130 milliseconds, provided a strategy to ensure biventricular capture is in place, or the patient is expected to return to sinus rhythm. The decision was made for CRT implantation, but still we are in dilemma whether the patient may benefit from CRT-P only, which is a CRT pacemaker, or you need to put a CRT-D. It's well known from the several trials that an ICD is beneficial for patients with heart failure with an ejection fraction less than 35, because mortality in such patient is too high for patients less than 35% ejection fraction of arrhythmic death. That's why ICD may be implanted if the QRS is less than 130. If more than 130, then CRT will be of benefit, especially with a left bundle branch block pattern. This slide showing the reassessment in April 2019, with the cumulative benefit of evidence-based medical treatment on reduction of sudden cardiac death, rates declined substantially over time in heart failure with reduced ejection fraction, and the effects of ARNI compared to angiotensin inhibition or ventricular arrhythmia is reduced with reduced ejection fraction. So in April, she was planned for CRT, but the question still arose: was the CRT-P is enough, or a CRT-D with a defibrillator may be of value? A sub-analysis of the Danish trial, which included more than 1,000 patients with a median follow-up of around 6 to 8 months, and it showed that they may benefit from the CRT-P, although the device may include an ICD to avoid sudden cardiac death or arrhythmic death in such patients. So 1 month after CRT-D implantation, which was in May 23rd, 2019, clinical status NIHA class 2 now rather than 3. Ejection fraction is still the same, and the N-terminal pro-BNP reduced to 551. Echocardiography was unchanged in comparison with the previous finding, including functional mitral regurg. CRT-D interrogation showed that the biventricular pacing estimate was 85%, which is too low for improvement of the patient. It should be above 95% at least. And the optimal medical therapy was not changed. Bisoprolol, sacubitril, valsartan, torsemide, spironolactone, apixaban, metformin, and dapagliflozin. What would be the optimal therapy to increase ventricular capture after follow-up of the CRT implantation? Add digoxin, which is AV node blocking agent. Consider DC cardioversion for atrial fibrillation, or consider AF ablation, or consider ablation of the AV junction. Most of the publications showed that AV ablation of the AV node, AV fulguration, we mean, of the AV node after implantation of a CRT-D is a good option to have more than 95% capture with biventricular pacing to improve the ejection fraction and resynchronize the desynchronous left ventricle. And this was done for such a patient. AV junctional ablation or fulguration was done to obviate the effect of the atrial fibrillation and the higher rate on the ventricular response of atrial fibrillation. This is my last slide, and I hope you have a good schema for management of such patient with heart failure, advanced heart failure, considering CRT, considering ICD, on top of optimal medical treatment, including ARNI drugs, which is an angiotensin receptor neprilysin inhibitor, and optimal medical therapy to improve the quality of life of such patient. Thank you, and hope to see you soon in another lecture.